A very good afternoon to you all. I'm going to skip a couple of slides which have been covered before, so please don't really bother about that. And we'll try to make it interactive, and on the same talk maybe we can have a bit of discussion going. I have no financial disclosure for this talk. Lid surgeries, the challenge is to get it right. So it should have a functional component, the anatomy should be restored, the lid should function well, and all the patients would definitely demand a good cosmesis. And all this can come if we combine all these talks. So starting from anatomy to the techniques of closure, how we are going to repair them. If we really do a good job and plan properly, definitely it will be a good functional outcome. So I do believe that with any of the reconstruction, the initial planning is the key. So once you get a patient, you might need to take photographs and then plan accordingly. Right? Surgical anatomy, let us skip. So if it's a small skin defect, which will be the case in non-marginal involvement, so you have a small lesion which you want to remove somewhere in the periocular area, the small lid defect or skin defects can be closed directly, and we can always use sliding flaps, kind of the shallow showed. The larger defects, which again, if it's a non-marginal involvement, usually will be the skin. So most commonly we are going to use grafts for that. And the common sites for harvesting would be upper lid, post-auricular and supraclavicular. I can just put a question for our panel here. Any age cutoff for upper lid grafts? Do you would like to avoid young patients for harvesting the lid graft, or it's okay? In old patients, there's quite a bit of lax tissue, so you can easily harvest. And in fact, you are giving them a complementary blepharoplasty, a part of it. But in a real young patient, would it be prudent to still take it as the best graft?
Generally, what graft you opt for depends on the size of the defect. And if the defect is very small, sometimes you can get enough tissue even in younger patients. But most often, the size of grafts that we need are usually only available in the older subjects where there has been enough laxity. So there is no principle in terms of cutoff age. Obviously, we will not get them in children, but in younger adults, sometimes they have enough laxity for us to get small grafts if needed. But most often, individuals older than 40 you're more comfortable in taking the grafts from the lid. Otherwise, there are other areas which you can opt for, including the post-auricular and the supraclavicular.
Fortunately, most of the patients who need reconstruction are of the slightly older age group in what we do. But first choice would be upper lid because it's very similar. But if you can't, then you need a sun-exposed area, which pre-auricular is in similar color, though different thickness. So my preference would be first upper lid if possible, second pre-auricular, third post-auricular, fourth is a choice between supraclavicular, upper inner arm, abdomen, etc.
And another question for you, sir, because this would probably relate more with the NHS system. What about the consent? So we are planning to take a lesion, and we thought we'll probably take the graft from the upper lid, and that's in the consent form. But because of the frozen section or whatever on table, you really need a bigger graft, and you need to switch. How do you manage the consent part there? What would be the right way of doing that? Because patient is under anesthesia. So any tips on
we get
that?
a wide range of consent. If there is anywhere where we can be found fault with is always the consent form, more than anything else. So if you have written in the notes that various options have been discussed, and in the consent form you clearly mention technique may be changed based on the finding, graft plus or minus mucous membrane plus or minus graft from other sites, then you get covered. But we all get complaints, we all get sued, and consent form and options are ones where we usually fall down, not in decision making, not in the surgery, but was the patient informed? You're absolutely right in asking that question.
I think it is always prudent to have plan A and always a plan B and even a plan C. You have to have alternatives because things look very different after you have completed an excision of a tumor than what you had assumed. So you always have to have alternative techniques in mind, and as Dr. Sampath said, it is vital that you have spoken to the patient about the variety of procedures that may be needed, and so that the patient is mentally ready for what he finds himself having had the procedure. So it is important that you have spoken to him about a much wider option than what you think initially.
So principle of repair, we can talk about them again because that's very important. And any round defect has to be converted to ellipse. We just saw a slide by Shalu there, because ellipse is going to get closed in a straight line, right? So most of the lesions, if we see, if it's a small lesion, 2, 3 millimeter, 4 millimeter, it will be irregularly round. Once you excise with margins, it's again still going to be a round defect. So you kind of extend it, make 2 triangles in the corner, make it an ellipse and close it off, right? So round is bad, ellipse is good. In upper lid, all incisions are parallel to the eyelid, or rather circular to the Langer's line. So that's what you can see in this photograph, and you can see the closure here. This looks real bad. You know, there's too much of an exposed area here. But see, it will oppose well. That's what sometimes people see here. You have in a BLEF patient, if they see on internet, which is something similar, they see something like this. They said, will I look like this? Or is it going to be that bad? How are you going to close it? So even this much, what you see, will close well if it's in a proper orientation. A small lesion here, if you see, being removed, the defect is converted perpendicular to the lid margin so that the suturing is that way and there is no notching. For the non-marginal reconstructions, flaps are preferred to skin grafts. So the skin graft would be our second option. The first thing is we would want to get away with flaps. Why? These are the reasons. Because they will be matching the original skin. It's a peripheral skin to the lesion which you have removed. So the match is good, blood supply is good. There is not going to be much of problem of take-up of the flap, unlike graft. There will be less shrinkage, and it will also match hair growth. Sometimes if you're taking the other side thing, the hair will differ. Direct closure sliding flap has been discussed. So in fact, most of our closure in lid surgeries, whatever examples we have shown, whatever you have clicked, are sliding flaps. Advancement flaps are when you are going to advance the flap to bridge the gap. So the distance is more. You can form these two kind of things. So there is a single advancement flap. So this is a lesion. You make a flap, then you pull it further, anchor it, it becomes a U. If it's a lesion and you really can't, it's a centrally placed lesion, you don't want to make it, you can take 2 flaps on both sides, suture it as an H. So it will become an H-shaped advancement flap. Rotational flaps, Tanzal Mustade, I believe Dr. Sampath is covering with the photographs and example. Trippier flap, Fricke's flap has been discussed with you. The most common thing here, I think, so this is another slide where we can have a discussion. We already had a discussion. Here we can have a discussion. So this is a standard way when we are going to mark and harvest a upper lid skin graft. So you mark, use a local or use a general anesthetic. Even if it's general anesthetic, I do use a bit of local to get some hemostasis. Harvest this and then use. This is one of the examples of post-auricular graft, a big basal cell carcinoma, removed, margins cleaned, and then I have taken a post-auricular graft and put up here. This is a long-term result after a couple of months. Most common complications with grafts could be bleeding, forming hematoma, which could form beneath the graft. That can create problem of take-up. You could have infection or a graft failure for certain other reasons. Late term, the most significant thing is graft contracture. Many of time, in spite of us sizing it well, we still encounter an occasional graft contracture. And I think so we'll like to discuss if there are further refinement tricks which you can follow to make sure that doesn't happen. And just last example of a medial canthal naevus removed and graft placed, looks good. Thank you for your kind attention.